So hello, everybody. My name is Christina Mangurian. I'm the Vice Chair for Diversity and Health Equity in the Department of Psychiatry and Behavioral Sciences, and it's my absolute pleasure to welcome Dr. Ruth Shim here today. For those of you who do not know her, Ruth Shim, Dr. Shim is the Luke and Grace Kim Professor in Cultural Psychiatry at the University of California, Davis, our sister institution. She also serves as the Associate Dean of Diverse and Inclusive Education at Davis in the School of Medicine. She received her MD and MPH at Emory University and then worked briefly in New York before coming out to California. She's published extensively, including several recent articles offering specific policy recommendations to eliminate structural racism in academic medicine and psychiatry. In fact, one article, Dismantling Structural Racism in Psychiatry, A Path to Mental Health Equity, was cited by the American Journal of Psychiatry's editor-in-chief as being one of the most influential and impactful articles of 2021. She's examined policies promoting mental health equity also associated with COVID-19, which led to, and I wasn't aware of this until recently, which led to her presentation of her findings for President Biden's COVID-19 Health Equity Task Force. She serves on editorial boards at JAMA Psychiatry, Psychiatric Services, Community Mental Health Journal, and American Psychiatric Publishing. And for those of you who don't know this as well, she's actually the co-editor of two books. One is The Social Determinants of Mental Health and the recently published Social Injustice in Mental Health. She's also a member of the Board of Trustees of Robert Wood Johnson and the American Association of Community Psychiatry, and serves on the Research and Evaluation Committee of the California Mental Health Services Oversight and Accountability Commission. For those of you who don't know, that's the Mental Health Services Act, and so that's the millionaire's tax here in California, which is dedicated to promoting innovative mental health services for underserved populations. Dr. Shim is also a former fellow of the Executive Leadership in Academic Medicine ELAM program and an at-large member of the National Academies of Science, Engineering, and Medicine Forum on Mental Health and Substance Use Disorders. And it's not surprise to me that in 2021, she received two awards. One is the NAMI Exemplary Psychiatrist Award and the UC Davis Dean's Award for Excellence in Mentoring. On a personal note, Ruth and I have known each other for many, many years. I'm absolutely in awe of her clarity in thinking and capacity to make very complex and often uncomfortable topics about racism and structural racism accessible to others and deepen their understanding to help us all together promote mental health equity and health equity at large. So she's a gem. And I'm actually delighted that she's here in real life. So I welcome Dr. Shim to you all here today. Please join me in welcoming.
Oh, thank you so much, Dr. Mangurian, for that incredible introduction. I'm really so pleased to be here in this beautiful building with all of the people that are here in person and all of the folks on Zoom. I'm just so pleased to be at UCSF and also to be invited here by Dr. Mangurian, who is a very close colleague and friend and has just been so supportive. I think we've been supportive of each other over the years, and so it's really just an honor to be here. I have a lot to cover in a very small amount of time, and so I want to kind of launch right in to the topic at hand. We're talking about social injustice and mental health, and we're really actually going to focus mostly on structural racism, but we'll highlight a couple of things. So we're going to go over several learning objectives today. We're going to define a number of concepts. We will have lots and lots of definitions. So just keep that in mind. We'll define social justice, social determinants of mental health inequities. We'll also define structural racism and many other things. We are going to consider how social injustice contributes to mental health inequities, and we're going to examine the role of social injustice in the field of mental health. Now, every time I give this talk, I have to make a number of disclaimers. We can't just launch right into talking about racism, unfortunately, in this society of ours. So I have to explain to everybody before we talk about it that this is a difficult and uncomfortable topic. I have to explain that as we bring up these topics, sometimes complex feelings emerge. Those feelings may include things like guilt, anger, resentment, or even defensiveness. And I have to make this disclaimer that you may perceive me of accusing you of being a number of terrible things, including perhaps racist or sexist or homophobic or any number of horrible things. And you also may feel during the course of this talk that I have some sort of specific political agenda that I am advancing or that I lack objectivity. I say all of these things in advance as my disclaimer because all of these things are things that I have been given feedback on when I have attempted to talk about these issues in the past. And so it is quite normal and natural for people to express these emotions directly towards me. I would say that it's important for us to recognize that these are difficult topics, but we still have to talk about them. And we have to acknowledge the difficulty of it because we're mental health professionals. And if we as mental health professionals cannot figure out how to deal with difficult things, then I really think that we're not able to expect other people to tackle these issues. So when we do talk about issues related to social justice, it's very, very hard. And it's hard for a number of reasons. But one is because we've been socialized to believe that it is not polite to talk about these things. And so this starts when we're really, really young. As children, our parents sometimes maybe would scold us or maybe admonish us for maybe commenting on someone's race or commenting on someone's appearance. And so we have really just kind of, particularly in the United States, skirted this issue. But more than that, in our health professional education, we have not been taught at all about the connection between oppression and injustice in health. And there's a very specific and deep body of literature and research that really highlights that oppression is bad for your health and it is very bad for your mental health. And yet this is all science that we don't typically traditionally learn in our educational settings. And the other reason why this is so such a difficult topic is because we're in the midst of what many people feel is a racial reckoning. So after the murder of George Floyd, millions of people took to the streets in the United States, but also worldwide. And there was incredible support for racial justice and the achievement of racial justice in the United States. But unfortunately, it says here the racial reckoning that wasn't, because that's exactly what ended up happening. And this data from the New York Times shows that as time has gone on, white people are less supportive of Black Lives Matter than they were at the beginning of 2020. So prior to George Floyd's murder, there were more white people that supported Black Lives Matter than there are now. And so that racial reckoning, that peak that we see in this graph of support for Black Lives Matter dissolved very quickly and dissolved among all racial groups, but particularly among white people, to the point that it is very challenging to talk and move through these concepts because there is not a sustained effort to try and kind of address these issues. So this is the last part of my disclaimer. And it is, as we try to talk about these issues as they're difficult, I find that the words of James Baldwin can be very sustaining and helpful. He said, "I'm not interested in anybody's guilt. Guilt is a luxury that we can no longer afford. I know you didn't do it and I didn't do it either, but I am responsible for it because I am a man and a citizen of this country, and you are responsible for it for the very same reason." So with that, we can actually finally launch into the talk. And so we are going to talk today about social justice and social injustice. And so we must define those concepts. Social justice is actually a term that has had a lot of controversy over the years. It is a statement, a principle that has become very politicized. And here is just an example of how that politicization of social justice has kind of seeped into medicine. In 2019, a physician by the name of Stanley Goldfarb, who was previously a dean of curriculum at University of Pennsylvania, published an op-ed in the Wall Street Journal called "Take 2 Aspirin and Call Me by My Pronouns." And he was really lamenting what he felt was the rise of social justice in medical education curricula. He really felt that the focus, the shift that he was noticing in the teaching of social justice in medical education really was not the right place or the right setting for this type of education. And one of the things he said in that article is, why have medical schools become a target for inculcating social policy when the stated purpose of medical education since Hippocrates has been to develop individuals who know how to cure patients? Curricula will increasingly focus on climate change, social inequities, gun violence, bias, and other progressive causes only tangentially related to treating illness, and so will many of your doctors in coming years. And so this is definitely a perspective that many physicians and many other providers have. And there was, of course, other perspectives on this as well. And so several of Dr. Goldfarb's colleagues at the University of Pennsylvania penned an op-ed in response to his op-ed that was published in the Philadelphia Inquirer. And what they said was that social justice is the foundation of healthcare and medical education. So they mentioned that social and health policies have always determined who gets sick and who gets care and where and how. Understanding the social drivers of health and illness is not peripheral or tangential to health. It is the key to diagnosing and meeting a patient's fundamental needs. So with that controversy in mind, let us define the concept of social justice. So social justice is in fact a philosophical term. And so the philosophers, David Miller, I think did the best job of kind of describing what social justice is. He said it is the distribution of good or advantages and bad or disadvantages in society, and more specifically, how these things should be distributed in society. So it is concerned with the ways that resources are allocated to people by social institutions. So that is one definition, and I think it's a pretty succinct definition about how we make decisions about who is worthy of advantage and who is worthy of disadvantage in our society. But we must add to that the definition of John Rawls, who said that social justice was assuring the protection of equal access to liberties, rights, and opportunities, as well as taking care of the least advantaged members of society. And that piece is, I think, most critical when we're talking about mental health, because due to oppression and a number of factors, people with mental health problems, and particularly people with serious mental illness and substance use disorders, often end up being the least advantaged members of our society. So it is very critical that when we think about social justice, that we're thinking about this intersection between social justice and mental health. Okay, so I mentioned we're going to be spending a lot of time talking about race. I have to kind of lay out some things about race and how we think about race and how we've traditionally incorrectly thought about race in medicine. The first is this idea of race being a social and a political construct. This is a really interesting concept because I heard it for years and years and years and had no idea what it actually meant when people said race is a social construct. And after kind of years of studying and trying to understand, it finally hit me that what race as a social and political construct means is that it was not something that is in any way accurately categorized through biology or through genetics or any other kind of way that we consider categories of people in science. It is something that was crafted, described, and created for the purposes of advancing slavery in particular, and particularly in the United States, but for other political means throughout the world. So it is a shifting societal construct that meets the needs as we define it of whoever has the power and is making the determination as how we would define it. And I think that that is really critical because the first thing that we have to think about when we talk about that is I'm not saying at all that race isn't important. It makes it almost sound like when we say something is a social construct, that it means that maybe it has less significance or less value or of less importance. And it has incredible importance and incredible significance. But it is not a biological construct and it is not a genetic construct. And I cannot draw somebody's blood and determine what their race is. And I cannot run a genetic test on someone and determine what their race is, despite the fact that there are physicians that actually believe that that is possible. What we do know is that race is a rough and imprecise proxy for a number of other things, including culture, genetics, and socioeconomic status. It makes sense to me then, if it is in fact such a proxy, that we should probably be measuring the thing that we're trying to understand rather than measuring race as a stand-in. But even though it is this proxy, we still use it to confirm a number of our assumptions, our prejudices, and our biases about our patients. Okay, so I have this quote that I want us all to ponder for a minute. It's a challenging quote, but I think it's important for us to think about it. African Americans have higher incarceration rates, higher unemployment, lower incomes, lower home and business ownership, less education, less healthcare, more disease, and lower life expectancy than whites. If you believe Blacks are naturally dumb, sick, criminal, you have your answer for these discrepancies. If, however, you resist using stereotypes to make sense of your world, institutional racism provides a very practical and very traceable explanation for the inferior societal position of African Americans. It's really important for us to ponder this quote because while we are all well-meaning, good people who definitely understand that institutional racism exists and definitely understands that there are reasons for all of these inferior societal positions, when it comes down to it in our kind of everyday practice and our everyday interaction with people, I don't think it's always front and center in our minds. I think we tend to revert back to thinking perhaps there is some sort of natural inferiority for this particular population. If we're being totally and completely honest with ourselves, I think that there is this tendency for us to revert back to thinking that way. And I think one of the reasons we revert back to thinking in this way, that maybe there is some sort of inherent inferiority, is because we've been primed to do so throughout history over and over and over again. And we've been primed to do so in medicine and in healthcare professional settings. And so I will give some examples of that. So in order for us to understand how we got to that situation, let's kind of go through a mini history tour. So this is this is the painting, Declaration of Independence by Turnbull. I think it's a very popular painting. We're all very familiar with it. It carries these great ideals about which our nation was founded. The signers got together, presenting this great document declaring our independence. And of course, this incredible monumental ideal, this language by which this country was founded, we hold these truths to be self-evident, that all men are created equal, that they are endowed by their creator with certain unalienable rights, that among these are life, liberty, and the pursuit of happiness. So such an incredible ideal by which our country was founded. But I think it's worth us mentioning and rehashing the importance that our country was really founded on this incredible ideal, but also on a lie. Because when these men got together and decided that they were going to craft the Declaration and create these ideals for this country, they were very specific that they meant this only for a very specific few number of people. First, they were just talking about life, liberty, and the pursuit of happiness for men. And then they were also really talking only about the men that existed here in this space, in this room. So really they were talking about these unalienable rights for white men in particular. And it should be noted that these men in this picture, almost all of them, actually owned enslaved Black people. So as they were espousing these rights, they owned other human beings. And so that contradiction, I think, has to be acknowledged and has to be thought about pretty deeply. We jump about 80 years into the future and we encounter this infamous physician by the name of Samuel Cartwright. This is someone who was not a psychiatrist, but actually claimed to have a level of authority around mental illnesses, and particularly authority around the mental illness of enslaved Black people in particular. And so one of the first conditions that he kind of highlighted was something termed drapetomania. He said that this was a condition in which an enslaved Black person would try to escape from captivity. And so the mental illness of wanting to escape slavery is how he defined it. He said in describing this condition, if any one or more of them at any time are inclined to raise their heads to a level with their master or overseer, humanity and their own good requires that they should be punished until they fall into that submissive state which was intended for them to occupy. They have only to be kept in that state and treated like children to prevent and cure them from running away. He also described another condition which he called dysesthesia ethiopica. He said that this was a disease of rascality, or the natural tendency of Black people to be lazy, and enslaved Black people in particular to not want to work hard. He said this was a mental illness in which if they were given too much freedom, too much liberty, they would get lazy and they would not produce in the ways that they had. And he said of this particular condition, the disease is the natural offspring of Negro liberty, the liberty to be idle, to wallow in filth, and to indulge in improper food and drinks. After the prescribed course of treatment, the slave will look grateful and thankful to the white man, whose compulsory power has restored his sensation and dispelled the mist that clouded his intellect. And I think, at the time that Cartwright came up with these kind of ridiculous assertions, it should be noted that there were several physicians who contradicted these statements and spoke out against them, some more rigorously than others. But it doesn't really matter how accepted or not accepted Cartwright was at his time, because these thoughts have been remarkably persistent. Particularly this idea that Black people don't work hard has been an incredibly persistent stereotype over time. And it's very bizarre to think that he would describe this condition when enslaved Black people were actually working at levels of productivity that were at levels that were kind of unseen for human beings. And they were doing this in conditions in which they were incredibly malnourished, did not have proper care, proper health care. And so to be able to produce at such a level and then to be said that you were lazy and that you didn't want to work hard is really kind of disturbing. But again, more disturbing that it has really been an enduring stereotype that has persisted all those years. Cartwright wasn't the first to bring it up, but he definitely advanced that theory. And then again, a couple of years after Cartwright talked about these conditions, we had the Dred Scott decision in which, and I bring this up because I want to point out the Supreme Court and the role of the courts in making policies that can be incredibly incorrect in how they decide on things. And this Dred Scott decision was related to the man, Dred Scott, who was in an enslaved state and was moved to a free state and then sued, stating that now that he was living in a free state, he should be free. The decision of the Supreme Court at that time, which was regarded as one of the worst decisions in Supreme Court, maybe the worst decision that the Supreme Court had, was that Mr. Scott did not have any claims to citizenship and therefore could not be free. And this particular statement from that ruling, we think that Black people are not included and were not intended to be included under the word citizens in the Constitution, and can therefore claim none of the rights and privileges which that instrument provides for and secures to citizens of the United States. On the contrary, there were at the time of America's founding considered as a subordinate and inferior class of beings who had been subjugated by the dominant race, and whether emancipated or not, yet remained subject to their authority and had no rights or privileges, but such as those who held the power and the government might choose to grant them. And so again, this is the Supreme Court. And I also just want to point out, surprisingly, when this ruling was made public, Samuel Cartwright found himself at the center of this action because he published an article kind of backing the scientific validity of this particular court finding in the paper at the time that this decision came out. I also just want to point out that Frederick Douglass stated at the time, the highest authority has spoken, the voice of the Supreme Court has gone out over the troubled waves of the national conscience. So history repeats itself. I would like to define a couple of other terms now. The first is health disparities. They are differences in health status among distinct segments of the population, including differences that occur by gender, race or ethnicity, education or income, disability or where you live. And I'd like to contrast that with the definition of health inequities, which are disparities in health that are the result of systemic, avoidable, and unjust social and economic policies and practices that create barriers to opportunity. It's really important to contrast these two definitions because here in the United States, given our history, given where we have come from, we tend to talk all the time about health disparities. We talk about differences in health status, but we say nothing about the cause of those differences. And when we use the term health inequities, which is the preferred term in other countries, we are talking about naming that the cause of these differences are systemic, avoidable, and unjust social and economic policies and practices. If you don't name the cause, and if you don't name it as kind of directly as saying it is unjust social and economic policies and practices, we then tend, if we don't have a cause kind of stated in the definition, we tend to seat the problem in the individual. We tend to say that the cause of the differences in health are either cultural differences, maybe that particular group doesn't value their health in the same way, maybe they're not as interested in caring for themselves, maybe they make worse health choices, or we might say that that particular group has some sort of biological or hormonal or some type of difference that makes them more likely to have this differential outcome. And so it's really critical that we kind of define the differences in health that we see in our society as health inequities, because in fact, they are health inequities. They are not health disparities, I would say most of the time. So one of the things that's important to do when we try to move forward in addressing structural racism is to develop a practice of self-reflection. And again, that's really important, especially when we start to feel all of these emotions and feelings coming up when we talk about these issues. We have to take a deep breath and kind of think directly and reflect inward about why we're feeling the way that we're feeling. So I'm going to help us kind of develop that practice right now by throwing out a couple of self-reflection questions for you to kind of deeply consider now or in the future when you're having lunch, maybe at dinner tonight. But the first one of these self-reflection questions is, when thinking about the differences in mental health outcomes among different racial and ethnic population groups, are we thinking about mental health disparities or are we thinking about mental health inequities? Think about how you have traditionally defined differences in mental health and the ways in which you have explained those differences, and make determinations about whether you're more likely to think that those differences are the result of unfair and unjust social and economic policies and practices, or whether you're more likely to think that those differences are some sort of internal difference in that population. Okay, so more definitions. The next one is the social determinants of mental health. Of course, these are the societal, environmental, and economic conditions that impact and affect mental health outcomes across various populations. These conditions are shaped by the distribution of money, power, and resources at global, national, and local levels, which are themselves influenced by policy choices. And the social determinants of health are prominently responsible for the health disparities and inequities that are seen within and among populations. Okay, so I'm going to take you through my thought process on this, a whirlwind tour through my mind. And it has gone from thinking about the social determinants of mental health, which is work I did with Michael Compton, in which we gathered all of the evidence that exists around how social determinants lead to poor mental health outcomes, and how that work really took me on a journey to really understand the role of social injustice in mental health. And that is work that I did with Sarah Vinson, in which we really tried to highlight what is kind of what I consider to be the basis of the development of social determinants of mental health. And so I'll walk you through that right now. So this is the figure, a conceptualization that I created with Michael Compton. And at the very top of the figure, you see adverse mental health outcomes and mental health inequities. As you move down the figure, you are moving further upstream. So one step down are a number of risk factors. And we know that risk factors precede an illness and increase the likelihood that someone might develop that illness. So these things could be reduced options, or what we call poor choices, or behavioral risk factors, or physiologic stress responses, or psychological stress. And so in mental health and in psychiatry, we spend a lot of time trying to intervene at the level of the risk factor. We do a number of risk assessments, and we try to make changes to prevent those bad mental health outcomes and to try to address mental health inequities. And what I've come to understand in thinking about the social determinants of mental health is that if you're intervening at the level of the risk factor, you're intervening too late, because there is a foundation that was created prior to the development of that risk factor. And so you have to intervene further upstream. So if you're going to move further upstream, that's where you get to the social determinants of mental health. And you see those things in those boxes in the middle. They are many, many, many things, including, and this is not an exhaustive list, but things like adverse early life experiences and discrimination and low education and unemployment and homelessness and food insecurity and transportation insecurity and adverse features of the built environment and neighborhood disorder, and we could go on and on. So again, those things are described as the fundamental causes of disease by Lincoln Phelan, and they're also considered to be the causes of the causes by Jeffrey Rose and Sir Michael Marmot. So as we intervene at the level of the social determinant, I spent years thinking this is where we need to target our interventions, but I've come to understand that if you're intervening at the social determinant level, you're still intervening too late, because again, there is more under that further upstream that is really driving the development of those social determinants, and that is social injustice. And so social injustice is something we would maybe call the causes of the causes of the causes. It is the thing that comes before the social determinant and sets the context for the development of that social determinant. And so that social injustice, what really grounds that and where we need to target our interventions are at two very important places, which are social norms, or how we feel about people, which gets back to that concept of social justice. Who do we decide in our society is worthy of advantage, and who in our society do we decide is worthy of disadvantage? And then based on those decisions that we make about people, we then pass laws, we create public policies that reflect that value system. And so those laws kind of interact with our opinions about who in our society has value and who does not. And that leads to social injustice, and that leads to the social determinants of mental health, and that leads to risk factors, and that leads to poor mental health outcomes. So I'm going to walk through that entire thing again with an example. And the example that I will start with is crack cocaine. And so when we think about crack cocaine, we have many, many social norms. Most of those social norms were created in the 80s, mostly by media. A lot of media images of dangerous, scary people using crack cocaine, and particularly our media perceptions, our social norms about the type of people who use crack cocaine were very racialized and very gendered. And so in particularly, we had images of Black men using crack cocaine who were dangerous criminals, who were violent predators. And we had images of Black women using crack cocaine who were bad mothers and who had no interest in anything except trying to get more drugs. And so that was kind of the perception. That was not necessarily the actual numbers of people who were using crack cocaine, but that was definitely the perception. That was the media perception. Because we had those social norms about the type of people who use this particular drug, we passed public policies that reflected our social norms. And so probably the most significant law that we passed that reflected these norms was the Anti-Drug Abuse Act of 1986. And this was the law that created the 100-to-1 jail sentencing disparity between crack cocaine and powder cocaine. And what that law said was that if you were arrested with 1 gram of crack cocaine in your possession, you would have the very same jail sentence as somebody who was arrested with 100 grams of powder cocaine in their possession. Now, keep in mind that powder cocaine and crack cocaine are the same chemical compound. So basically, there was this inference that the people that were using this particular drug were somehow more deserving of a harsher penalty than the people who were using that particular drug. And I think the other thing that's important to think about here is that clearly 1 gram of crack cocaine is for personal use. That is identifying a substance use problem, whereas 100 grams of powder cocaine is for distribution, for sale of that drug. And so to give the same punishment for these conditions is really kind of nonsensical. But let's point that out and kind of and walk through the figures. So that is the public policy that led to unfair and unjust distribution of opportunity and led to greater incarceration and mass incarceration of Black people, which then triggered a number of social determinants of mental health. So if someone finished their jail sentence and got out of jail after serving, we know that incarceration, of course, is a social determinant of mental health. But if they got out of jail, they would then have difficulty getting a job because you have to check that box on your application that says that you have a felony. And so if you can't get a job, that interferes with your income, and that increases your likelihood of being in poverty. If you're in poverty and you don't have a job, it's very hard to have stable housing. It's very hard to have access to healthy food. So it triggers a number of things. If you don't have a job, it's highly unlikely that you will have health care. So all of these social determinants are triggered by this particular policy, this unfair and unjust policy. But worse than that, it has intergenerational effects, because we know that, and one of the adverse childhood experiences that one can have is having a parent who's incarcerated. So this is kind of far sweeping implications that this particular policy has had, that has triggered a number of social determinants of mental health that have led to massive levels of mental health inequities. And I want to point out that we talked about, where do these interventions come from? And so we want to think about, how would we intervene at the public policy level then? And so that's why in this figure, you notice it says that there's an 18-to-1 jail sentencing disparity on this figure. And that's because after many, many years of intensive lobbying and pushing and efforts to try and eliminate that jail sentencing disparity, in 2010, a law was passed that reduced the sentencing disparity from 100-to-1 to 18-to-1. So based with all of the science and the data, lawmakers refused to eliminate the sentencing disparity altogether, but the best they could do was say that you get the same sentence for 18 grams of powder cocaine now than you do for that you do for 1 gram of crack cocaine. I will also point out that every year legislation comes before Congress trying to eliminate this 18-to-1 jail sentencing disparity, and almost every year it does not get out of committee. And then the last point on this is that is what Ernest Drucker said around the ways that we think about treating crack cocaine substance use disorder. And he said that the fundamental clinical accountability of drug treatment professionals to individual patients has been subordinated to the goals of the criminal justice system. And so let's contrast that with the ways that we think about the opioid epidemic, in which we don't think of this particular substance use disorder as a criminal justice problem. We haven't subordinated it in any way. We think of it as a public health problem. And we very much, because of our social norms around the people who use these particular drugs, we have enacted very different policies on how to address these things. And that has led to a number of different social determinants of mental health. Of course, it doesn't mean that the opioid epidemic is something that we have solved or come close to solving, but we don't see the level of inequities that have been triggered by this epidemic in the ways that we have seen with the crack epidemic. Okay, I have more definitions for everyone. And I think that it's important to talk about a number of critical concepts. The first is this idea of essentialism. Essentialism is the belief that there are distinct, unchanging, and natural characteristics that define social groups and facilitate their categorization, things like race or ethnicity or gender or sexuality. We, particularly scientists, but us in fields of medicine and mental health, we really love to categorize people. And sadly, human beings are not so easily categorized. And yet we still believe that we can put people into these very neat boxes when in fact, humans resist categorization. So we really need to think about what we're doing when we're doing this categorization and essentializing, as we would call it. And then we can talk about erasure of context, which is the failure to consider the socio-historical context when seeking to understand the etiology of inequities. And this is really borne out in Cartwright's theories. Clearly, if he had any sort of ability to see the socio-historical context of what he was examining, he might be able to understand why his beliefs and his theories were incorrect. Biological determinism is the false belief that racial groups are biologically and genetically different. And this is an enduring concept that sadly a lot of physicians believe in, that racial groups are biologically different. That is that infamous 2016 Hoffman and et al. Study, which found that medical students believe that Black people have thicker skin than white people and that they have less nerve endings, is kind of highlighting biological determinism. And then cultural determinism is the cousin of biological determinism. It is the false belief that racial differences are the result of cultural factors. So dietary choices, for example, and that our cultural, our decisions that we make as a culture are the reasons why we see these things, again, without understanding the socio-historical context of why that culture makes certain decisions, but also that that culture doesn't actually drive the inequities that we see that are the result of unfair and unjust opportunity. So another self-reflection question for us: what are the theories of biological and cultural determinism that I was taught in my medical and psychiatric education and training? And once you start thinking about these, they will pour forth, I promise. In the little bit of time I have left, I have a few more definitions and then hopefully some solutions. I want to talk about oppression, and particularly these are the 5 phases of oppression as described by Iris Marion Young. She talked about exploitation, which is the unequal exchange of one group's labor and energies for another group's advantage and advancement. Clearly, slavery is the best example, one of the best examples of exploitation, but we should point out that there are many, many examples of modern day exploitation, including human trafficking, but also the ways that we treat migrant farm workers, the ways that we treat warehouse workers in particular. So lots and lots of exploitation going on in society. Cultural imperialism is establishing the ruling class culture as a norm and othering all those groups that are not part of the dominant culture. I see this most commonly in research, in which when we're doing odds ratios, we always, looking at racial categories, we always refer to white people as the reference group without thinking about it. And it's because we consider that group to be the normative group, and then all of those others are the ones that we have to kind of compare to. Powerlessness is when oppressed groups lack power or block from routes to gaining power. Clearly, voter suppression is the clearest example of that that's happening today. Marginalization is expelling specific groups from meaningful participation in society. Clearly, marginalization impacted indigenous populations in this country and still continue to do so. Also mass incarceration, also particular laws like the Chinese Exclusion Act and Japanese internment. And then violence are threats and experience of physical and structural violence. This is an important time to bring up the concept of intersectionality and how when there are multiple oppressed identities, oftentimes these types of exploitation, these types of oppression become even more salient, particularly thinking about the physical and structural violence that is committed against trans people of color in the United States. Okay, I have finally to define structural racism as a system in which public policies, institutional practices, cultural representations, and other norms work in various, often reinforcing ways to perpetuate racial group inequities. This system identifies dimensions of our history and culture that have allowed privileges associated with whiteness and disadvantages associated with color to endure and adapt over time. It is not something that a few people or institutions choose to practice. Instead, it's been a feature of the social, economic, and political systems in which we all exist, and it does not require the actions or the intentions of others. If we got rid of all of the interpersonal discrimination that exists in our society today, we would still see racial and ethnic inequities due to the persistence of structural racism. Okay, I recognize that I am almost completely out of time, but I have just a few more things that I'm going to fly through. So I'm going to talk a bit about social injustice and psychiatry. And we've talked about the war on drugs. I'm going to skip over Immigration and Social Security Act and really briefly talk about residential segregation and mental health care before I wrap up. I think like 3 more minutes. Yeah. Okay. So so here is data that shows the excess risk of Black people having to travel more than a mile to the closest potential vaccination site for COVID. And so what this data showed was basically Black people have to go, Black people and people who live in predominantly Black neighborhoods have to go significantly farther in many, this is just 3 counties, but in many counties across the United States have to go significantly farther than people who live in predominantly white neighborhoods to get to the first vaccination, COVID vaccination site. This data is so salient around the health disparities and equities point, because what many people said about Black people not getting vaccinated was that they were vaccine hesitant, that they had cultural beliefs and values that made it that they did not want to be vaccinated. But not a lot of people talked about the structural barriers that made it very hard as a result of residential segregation, made it hard for people to access vaccination. And then this is data from SAMHSA that showed in 2018 that 69% of Black adults and 67% of Latinx adults with any mental illness received no treatment. 42% and 44% of Black and Latinx adults with serious mental illness received no treatment. And 89 and 88% of Latinx and Black adults with substance use disorders received no treatment whatsoever. And really, when we think about this, we have these stories in our mind. We say stigma. We say these populations don't want to seek help. These populations have less insight, but cost was the most commonly cited reason for not seeking care. And that was twice as often as minimizing symptoms and nearly 5 times as often as stigma. So in the 1 minute I have left, I'm going to talk about where we need to go. So we're in this state of inequality with unequal access to opportunities. And many people think that we need to reach this point of equality. Many people think that the solution is where we focus on fairness. Whatever we do to try and fix this problem, we have to be fair. We have to make sure everybody gets the same. But that will not cut it, as you can see with this figure. So we have to focus not on fairness, but on equity. Equity is when you customize the tool to identify and address the inequality. You give the population what they specifically need to be successful. But we have to pair that equity with justice, which is when we fix the system to offer equal access to both tools and opportunities. And so there are a number of things that we need to do, and I'm going to fly through them super quickly. The first is we have to develop a practice of education and self-reflection. There are a number of books here. You'll be able to access all of these. There are podcasts. I'll make sure you guys have this information. Here is a self-reflection question for you. How much time have you committed to learning additional information about these topics, especially considering that they are not traditionally taught in educational settings? We must practice cultural humility. And I think the first part of this concept is most critical. We have to develop a lifelong process of self-evaluation and self-critique. We can't take one class and solve this problem. And we have to couple cultural humility with structural competence, which is how we see and how we discern as clinicians how symptoms and problems are influenced by upstream social determinants of health. And then we have to promote social norms of inclusion, equity, and respect. And that involves enforcing and educating and legislating to change social norms, observing and challenging our own biases, and breaking down unnecessary hierarchies, and advocating for equitable policies by moving beyond our clinics and our hospitals and our treatment centers to advocate for those policies through communication with elected officials and promoting of equitable representation, and advocating and centering the experts and people with lived experience. And so to wrap up, and I am now ready to end, political stances and policy interventions are required. Because if we remain apolitical or neutral, that is in fact a political stance because you are tacitly accepting the status quo. And so we have to get comfortable speaking up. And in the words of Audre Lorde, she said, when we speak, we are afraid our words will not be heard nor welcomed, but when we are silent, we are still afraid. So it is better to speak. And I will end with one final thought, which is that when we think about all of these concepts, we think about how much progress we've made over time, and we've made incredible progress. And progress is made through the passage of legislation, through court rulings, and other formal mechanisms that aim to promote racial equality and other forms of equality as well. And I think it is very important, and particularly in these times, for us to recognize that whenever we make progress, always comes inevitable retrenchment. And retrenchment refers to the ways in which progress is very often challenged, neutralized, or undermined in key policies and in key policy arenas. And we're in a state right now, and have been for quite some time, of deep retrenchment. And we have to make sure that we do not lose hope and that we do not despair. And so I leave you with the words of Congressperson John Lewis, who said, "Do not get lost in the sea of despair. Be hopeful, be optimistic. Our struggle is not the struggle of a day, a week, a month, or a year. It is the struggle of a lifetime. Never, ever be afraid to make some noise and get in good trouble, necessary trouble." Thank you.
Okay, this is going to cause an echo, right?
I think if you stay
away. Okay. I'm trying to make sure the people online can hear this. So outstanding talk. Would anybody in the audience, does anybody have any questions?
Hi. Thank you so much. It was wonderful to hear you speak, and I have a question, which is a little bit personal. So I noticed you spent a lot of time at the beginning with your disclaimer to call us in. How long in your career has it taken you to sort of get to that, where you sort of anticipate the defensiveness, the response, and you essentially try to make sure that your words are heard? Like, how long did it take you to sort of get to, if I don't do that, it just doesn't work? And I really noticed.
Thank you for that question. I very much appreciate it. And yes, I have a long answer to that, but like my short answer will be, I have a long and interesting story that I'll tell you sometime. But my short answer to that is that after receiving a lot of racist feedback, after time, I realized that I needed to prep people, and it took a while before, it took a number of racist evaluations before I realized that I needed to start practicing speaking up more. And so there was a period of time in my career where I used to actually like put up some of the worst racist evaluations to kind of ward off people from thinking that they should be doing that, and it was highly effective. If I said if I just put up an evaluation written word for word about how racist somebody was and what they said about my presentation, that almost always prevented someone else. And so there was a long period of time where I did that at the start of all of my talks, and then didn't have to be subject to more racist evaluations. But now I think it's become very clear to me over time, in the period of time that we've been doing this work, and particularly work from Robin DiAngelo around white fragility, that people need to be prepared in advance. And so it is the more scholarship that I do in this work, the more it becomes clear how much preparation people need and how critical that preparation is, and how most of the time the preparation isn't done. And that's how many people are not reached in trying to share these thoughts. So thank you for the question.
Thank you, Dr. Shim, for sharing your excellence with us today here. My question is around the latter portion of your talk, which I hope we can think more about later today. In academia, we are not necessarily rewarded or noted or reinforced for making those policy efforts. The criteria are revenue, clinical visits, publications, talks, etc. What is your recommendation to leadership around the country in academia in terms of what they should be looking for and reinforcing so that we can move the needle on public health and social
That's a great question. So it requires leadership that really, really understands how significant structural racism is in academics. And unfortunately, most of the current leadership structure as it is set up in academia is not there. I have said before that I have seen incredible strides be made by institutions in which a white man in particular has taken the time to educate himself on structural racism and push for change, because we still live in a society where his opinion matters above others. And therefore, if he is really focused on advancing these issues, incredible work can be done. But that requires a significant commitment from our leadership, and particularly our majority white, majority male leadership, to really commit to doing the level of intense work, all those books and reading all those resources and doing all this self-reflection that few people are willing to do. And so short of that, I think that would be the quickest path to getting to where we would need to be. But I think if we go down that path, the other place to get to that path, and I think they inevitably intersect at the end, would be to have leaders of more diverse backgrounds in positions of leadership. And those leaders would have, hopefully, a better understanding of these concepts and would be able to prioritize different things like policy work, and pretty much change the rules of academia. And so again, I think that both of those things can kind of come together and work together, but it does require the people who currently have power to be willing to give some of that power to other people, and recognizing that in giving that power to others, that would actually kind of strengthen all of us and benefit all of us. And that's a tall order for people who haven't spent enough time kind of thinking about this work. So it's a challenging place to be, but I remain optimistic that one day, I mean, I might not be around for it, but we'll get there eventually.
Thanks so much. Great talk. And one very brief comment and then a question. The comment is just, I really like your model of sort of thinking about values and norms, social norms, and then policy, and sort of looking at that as an intervention target. And one of the things that it really got me thinking is this intermediate issue that we're facing right now, which is sort of the lack of translation from norms to policy because of the way our democratic process is functioning. And just thinking about that as another point of intervention, like gerrymandering. I mean, these are policies fundamentally, but things like gerrymandering or the filibuster, or reasons why like norms can change right now, but it doesn't. It's often seemingly not translating to policy because of these process issues. The question I had.
Can I make one comment on that? I love that point, and I have like competing thoughts about that, because in one way we can look at our current governance system and say, yes, these norms aren't translating, and that the government is not reflecting the social norms of the population. But I think we could also easily make the case for maybe the government is absolutely reflecting the social norms by which the people who have power want, and they are passing laws based on those particular social norms, which are different from the social norms that we espouse here or talk about, but that they are advancing their particular social norms in which they value certain populations over others, and they're very effective at that. So I think there is some debate about how effectively we're operating. I think somehow, people talk about how the system works the way it was designed, and I think that in some ways our laws reflect that they're operating the way they were designed to work to benefit certain populations.
I'll save my question for.
Oh no! Oh no, you can ask.
I appreciate that comment on process issue, by the way, but the question actually had to do with organized psychiatry and where you, I know you've had a complicated relationship with organized psychiatry vis-a-vis these issues, and I'm just curious where you see things, where you feel things are at right now with the profession and its role in addressing these issues.
Yeah, thanks for that question. And I think it relates to the previous question. Unfortunately, I do not see organized psychiatry, still do not see organized psychiatry as doing enough and doing nearly the level of work and the intensity that needs to happen for us to kind of move forward on these issues. There's, I think that as we talked about before, there is deep work that needs to happen by people in leadership to get to a place in which they understand these issues. And unfortunately, organized psychiatry has not demonstrated to me, and still has not demonstrated to me over the time in which I decided not to be affiliated anymore, has still not shown itself to value really deeply doing the necessary work on these issues. So sadly, I don't think a lot of progress has been made. I think that there's been a lot of talking and a lot of hand waving and a lot of performative action, but that has not necessarily led to any real change.
Well, on that note,
Right.
thank you very much, Dr. Shim, for being here today. And thank you everyone for being here. And for the trainees on the call, there is going to be a coffee with Dr. Shim later today. If you've not heard about it, please let Gina Martinez know about the location. I'm just so grateful that you came. It was such a great, wonderful talk.
Thank you.